long time, which is a screw tail in a bulldog. And so the anus is down here. That's dorsal, ventral, left side, right side. And so we've got these really deep crypts all the way around the anus, which are just so inflamed and look like they would be very, very painful. So we're going to do a very high, deep screw tail amputation, and that should be curative. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications, and also consider joining our YouTube membership. So what I'm going to do is we'll just pull this in. Do you need a stool? Okay, that'd be great. And just watch your head when you're on the stool. All right, so what I'm going to do is a circumferential incision. I'll show you how deep that crypt is. So I've got a right angle forceps here. You can see how far in that crypt goes. So that's about 4.5 centimeters there. So I might get a set of towel clamps here. So just hold on there. And so as you guys are aware, I always like to, whenever I'm incising anything, to have it under tension. That makes it just so much easier to cut. So I'm just going to come around the top first. Mel is being very trusting of me with the scalpel blade right next to her finger. She has 9 more. Not sure what she's complaining about. You can zoom that out. Let's see if I can zoom that out just a little bit. Okay. All right, so we've got tension on the, go ahead and pull down there, tension on the skin. And essentially I'm just going to cut through the skin, and then I'm going to start retracting it so that I can tunnel. So I'm incising to make sure that I'm excising all of the abnormal skin. Can I get, please, some more towel clamps? Thank you. Now we will encounter the coccygeal vessels that we'll have to ligate. So I've got the lazy ligature. I can feel the tail, the base of the tail right there, or that spine, so the coccygeal vertebrae right there. And these are really painful, as in the condition is painful, not necessarily the surgery. All right, so now we'll lift this up. We'll come around the bottom side. I might get my Gelper retractors just to try to pull some of that skin out of the way. Then we'll pull that forward. And these Gelpies are really helping me make sure that I'm getting around all of that inflamed tissue. So I'll come around the side here. And there's some potential risk for you to make a dog incontinent if you inadvertently tether on the spinal column when you're excising it. And there's a very robust blood supply here because of the inflammation. And I wouldn't be at all surprised if some of the GPs in practice have done more of these than I have. I've only done a few of them. The key is just to make sure that I'm getting around all of the diseased tissues and all of those crypts. Alright, so we'll get our Gelpi retractor in here. I'm going to come around the other side. Lift that up. Just grab this a little deeper here. It's not the most glamorous surgery in the world. It's very gratifying because you can imagine that this dog is just going to be so much more comfortable after this procedure. And it's important whenever you do any kind of surgery to continually reposition your retractors to make sure you're getting the maximum exposure. Just really lift that up like that for me, please. Thank you.
Were you able to estimate after it was under roughly how deep the crypts were?
About 4 centimeters. I can see what looks like probably anal sphincter here dorsally. And I'm not concerned about that at all. I'm just kind of working, go ahead and let go. Lift that up like that. I'm just kind of working circumferentially.
Yep.
Really lift that up, please. Straight up. Yep, thank you. Let's see what we've got here. Come up like that, lift that straight up. And straight up. Thank you. The iron intern. I'm treating it almost like it's a tumor, so I don't want to cut into that inflammatory tissue at all. Getting down there. Okay. Pull that like that.
Is this considered clean contaminated? Is the infection in the tail?
Clean contaminated, yeah. So for you guys on the live stream, Cameron just asked if this would be a clean contaminated surgery because it's infected, and I said that that was correct. Let's pull this down like that. And lift that straight up like that. And up and out. So I'm down to bone right there. And then a little bleeder here. Get this Gelpi in a little deeper. Again, just continually repositioning my retractors to make sure that I'm getting the optimum retraction.
You've got two questions if you'd like me to read them to you.
Yes, please.
So you're removing from the last coccygeal vertebrae.
I'm going up as much as I need to get around the crypt. And so basically this is as far as I need to go. I don't know which vertebrae this is, but I don't need to go any higher than where the crypt is.
And then the second comment, this vet is concerned about doing screw tail amputations. Any tips to avoid complications like incontinence?
So when I cut this, so the question is any tips to prevent incontinence. When I cut this, I just have to make sure that I cut all the way through the nerves before I pull on that end. Because if I cut just through the bone and then pull on the nerves, that's what can lead to the incontinence. So I'm going to go ahead and cut the bone now. Do a bigger bone cutter. And I think I'm through the bone, but I'm not going to tether on it until I'm 100% sure. And in dogs that have, particularly cats actually, that get run over by a car, and they have their tail caught under the tire and it yanks the tail off, that's called a tethering injury. And you can definitely have urinary and fecal incontinence occur with that. All right, so I've cut through the bone.
Is that the strain that it puts on the spinal cord up near us?
Yeah. Yes. So now I'm just coming around the side. Yeah. Yes. So our anesthetist is just asking if we can give some fentanyl because he had methadone about an hour ago and he's still reacting.
Could we do a local block?
Yeah, we will. We'll inject it right up into the nerve roots. So now I'm through the bone, and so I'm just going to make sure that before I pull on this, I cut with scissors all the way through. And that's the ventral coccygeal artery right there. Might grab that with a thumb forceps. I'll just cauterize that. So that's the ventral coccygeal vessel right there. And I've just cauterized that. All right, so that's done. Have a little bit of a bleeder there, and that's the mess we've got there, so we can invert that. You can see how deep that crypt went, and you can see that we've excised the entire crypt there. Nasty little thing. All right, so that's the lateral coccygeal. So you've got two laterals and one ventral. I might need to pack that off. Can you just put some pressure there? Can I get some epivocaine, please? Thank you. And so I'm just going to inject this straight up the spinal canal. Can I get a 22 gauge needle, please? Right, so let's see if we can find this thing here. It is not there. It's kind of there it is. So I'll inject a portion in there. And then I'll lift this up and I'll just inject the rest around here. Can I get some OPDS, please? So we're not going to do any post-op antibiotics. We're just doing intra-op because we're getting rid of the source of the infection, so there's no reason to put it on antibiotics afterward. Yeah, so just cefazolin during the procedure, yeah. Alright, so now, let's get rid of that guy. Potentially. CSF leak is not really a big deal in dogs. It is a big deal in humans. Both, please, at about 3 mil. Thank you. What I'm going to do is grab that little bit of skin here and have you retract that up for me, please. And that doesn't have to go too high. This is just such a lovely dog. Named Buddy. Yep.
The ones you place down there in bulldogs?
All bulldogs, yeah. Imagine that any brachycephalic could have it. But the ones I've done have all been bulldogs. What's that, Karen?
Just commenting that you can play with questions, yeah.
Yeah. Can you zoom right in? I can do it. I'll just grab onto. So just to show you a slip knot. Just move that up a little further. And you could do an epidural. We just injected right into the nerve or the spinal canal, and with mepivacaine. All right, so what I'm doing is I've buried both my ends. So I've gone deep to superficial, superficial to deep. And then I'm going to do one throw like this and leave it loose. The other throw like this, leave it loose, and then just pull on the one side so it slides down, and then pull it apart to lock it off. I'll invert my suture again so you can see from the outside. So this one's going superficial to deep, deep to superficial. And I take one bite, leave it loose, the other bite, leave it loose, pull on the one side so it converts into the slip, pull it all the way down, and then pull it apart to lock it off. Much more secure, and it conserves suture, because you can slide it right down, so you only have about a centimeter left. I'll demonstrate that again. Okay, first throw, leave it loose. Second throw, leave it loose. And then see, I've got a couple of centimeters there. I'm just going to pull on this end so that it tightens up, and then I'm using up some of that suture. So now I've got less than a centimeter of a tail there. You cut both of them below the needle driver. Yep. Alright, so let's see, we've got a little oozing here. Can I please get some 2O PDS? You can release that one, please. As in you can detach it from the skin. Thank you. And then this will be just a simple continuous, kind of a deep sub-Q. And then I'll have Mel do a intradermal. So both of these ends are deep. So I went superficial, or deep to superficial, superficial to deep. Convert it into a slip knot, pull it right down, and then pull it apart. Just got new glasses this week, and I can't believe how well I can see. I went from a 1.5 magnification to a 2.25.
Still not that bad.
No.
I think Leon's is like a 6.
Right.
He can't see the shampoo bottle.
Right. We don't know, but we think so. So the place that you see phantom pain would be with like a hind leg amputation, and occasionally they'll yelp and bite at their incision.
Yeah.
And we assume that that's probably phantom pain. I'm not sure how else we could establish that.
Yeah, so if he continued to show interest in his surgical side after the amputation failed.
Yeah, you'd try something like gabapentin or... usually 4 squares, 4 throws after the slip. So you want a total of 5. 5 or 6, sorry. I wonder if humans have anything like this with their coccygeal vertebrae. I know you can get pilonidal sinuses and stuff. Alright, so I'm just going to leave it to Mel to finish the intradermal, and I'm going to wrap up the live stream in a minute, but thank you very much for watching. So video is free to everybody right now, but as soon as I get back to my office, I'm going to put it on the membership. The membership really is only to support our marketing and to purchase good camera equipment and stuff like that. We've never made any money on VetDojo or on the YouTube membership, so it's essentially a non-profit organization. Not intentionally, but that's the way it's worked out. So it's a labor of love. So if we can get people to join that membership to make sure that we can continue to provide the great content that we do on YouTube. So thanks a lot for watching, and we will see you again soon. I do possibly have another live stream today, which would be maybe a patellar exploration, stifle exploration for patellar luxation after a TPLO. So thanks again.